people that are viewing this have been sending their questions. So I'm going to read out some and then ask any one of the panelists if they want to discuss. There have been a number of questions questioning the toxicity, and one of our participants have asked, if several teeth have to be treated, is there not concern that young children will have an overdose or there'll be some systemic effects of the SDF? Would anyone like to comment on that? CH, do you want to unmute yourself? Is there concerns in the kindergarten studies that you've done that if multiple cavities have to be treated with SDF, there would be some concern about toxicity?
Actually, we just apply SDF to the caries lesion. According to we don't receive any, over the 10 years, I would say we never receive a single case that with a severe long-term complications so far. This is what in our protocol. Actually, we apply almost all the caries lesion onto our children group.
Okay.
So actually, we are going to analyze the result and publish it later on. Okay. But as far as I know, yes, it's a very highly concentrated solution, but you look into the amount of fluoride applied. Actually, we have a laboratory study. Actually, the amount of fluoride we apply is less than sodium fluoride varnish, because varnish is fake. When you apply a application of fluoride varnish, you did apply quite significant amount of fluoride to the caries lesion compared with the the solution that we apply to a single cavity. So we did have some data to show the amount of fluoride we apply per application of SDF is actually lower than the SDF, lower than the sodium fluoride varnish.
Okay, good, thank you, CH. Does anyone else want to comment on these toxicity concerns? No, I've been using SDF for over 5 to 6 years, and I've had no issues at all with regard to toxicity. Another person participating has asked the question of using SDF and people's experience with seniors, with older populations. Has anyone would like to comment on that, about the value of SDF in care homes, in domiciliary visits? Jeff, is there, you need to unmute yourself, sorry.
Okay.
Sorry, Jeff, you need to unmute yourself, but we were asking a question about experiences with seniors and in care homes and domiciliary visits.
Yeah, well, I've seen it mainly in general practice. I see a lot of older people in general practice, and again, that you're reluctant to do too much for them, particularly if they're quite ill as well. And the benefit is that I just apply I etch it first, apply the silver diamine fluoride. It has dramatic effects, particularly when that person with xerostomia, and they can come and see the people's mouths disintegrate in front of you, and in 3 months' time they've got a whole new raft of cavities. The silver diamine fluoride is very effective at actually sort of arresting certainly root caries in elderly people.
Sure, thank you. Okay, Rick, can I ask you specifically, there's a question here that someone's asked about, is there any place for a traditional school-based service? I think they are referring to the fact of visits to schools to provide traditional care in the normal way. Do you feel the evidence base now is sufficient to discredit that type of approach?
I hate to say that there's evidence to discredit something that we've done for 100 years. and create a firestorm. That said, I support Pratik's notion of moving from drill and fill to seal and heal. The data does indicate that once you start drilling and filling, those fillings are not permanent restorations. They last 5, 10, 15 years, and then they need to be replaced with larger fillings. So that ultimately, once a patient or a dentist starts down that path, the benefit for the dentist is an annuity. That patient, if they keep coming back, that dentist is going to have an annuity replacement, and they're going to make more income. So that's all to the good for the dentist. That's not to the good of the patient. So my ethical, moral approach to this is to continue to do prevention. Glass ionomer can be applied without any drilling and filling and maintain the coherence of the tooth. So from a patient's perspective, although perhaps not from the financial perspective of the dentist, I'd advocate for the MID, for the minimal intervention, and replacing it without any drilling. So while I said I wasn't going to jump into a firestorm, I'm a huge advocate for minimal intervention versus intervention.
Good, thank you. We have actually a comment who's asked the question that whether all children, if they have cavities, of young children here, I think they're referring to preschool children, the first course of treatment should always be silver diamine fluoride until the dentist is confident that the child will be able to have a more traditional restoration. Pratik, do you want to just comment on that? Do you think SDF should be the first line in the treatment strategy for very young children?
I think it will depend on the severity of the lesions, because right now we can have a system to make an early detection. There are some early caries, like the white spot lesion. SDF might be not really necessary, but I think that SDF it will have a good application when the caries come to the dentine, especially. So if it's come to the dentine caries, the SDF might be a good way to stop the progress of caries for the future. And so I think the dentist or the dental nurse should be a bit more careful to make the early detection, so that for early prevention. But what kind of prevention? It depends on the kind of management that will be better for the children. But it can be used in the young children as well, if the caries is up to the dentine caries. I think SDF is still very safe to use in the young children, I believe.
Yeah. Someone has asked on developing that is that the Hall technique is being advocated. This is the technique where you place stainless steel crowns on symptomless primary teeth that have large cavities. And I suppose the question is whether SDF should be used in the first instance before putting on a Hall crown as a technique. Jeff, is there any comment you want to make on that?
Am I unmuted?
Yeah, you're unmuted.
Hear me? Okay. Yeah. Look, I've seen a lot of kids get these Hall crowns, and I think it's really important to the whole idea is to do as little as possible to get the effect you're after, and putting on silver diamine fluoride, certainly with a glass on a cement overlay, and this is the sort of thing that I've been doing with a team up in East Timor and Papua New Guinea, and it doesn't create a restoration if you just get a bit of Vaseline on a glove and just smear it over the surface to keep it out of the occlusion. You're going to get a few food packs, but you don't see children coming into emergency clinics with food packs, where you certainly see kids coming in emergency clinics with dental abscesses. So if you can do it, if you can do this, if there's a problem and the tooth sort of keeps disintegrating, then go to the Hall technique. But the whole technique was developed before the advent, or before we were actually realised the benefits of silver fluoride. So from every aspect, the delivery of the cost of delivery of care to the ease of application. Many kids generally can have a general anaesthetic to put a whole crown on. So I would advocate, firstly, do what you can first with silver diamine fluoride with a glass element cement overlay, because I think that's a permanent, or not it gives a better outcome than 80% that we just get with silver diamine fluoride by itself. And then if problems develop, then go to the next technique, which is the whole technique.
Okay, thank you. There's a question here about children with disability, and I've looked to the New York experience and Hong Kong. Did you encounter the acceptability or the impact that the silver diamine fluoride had on children with disabilities? Was that part of the program? Rick, was that part of your New York program?
We have integrated, not we, New York City and New Hampshire, where we're working, integrate children with disabilities. They mainstream them, and we're treating everybody similarly. Obviously, children with disabilities take more time, but it's equally effective from what we've seen. So there isn't any differentiation between mainstream kids and kids with disabilities. The biology of caries for all people is the same. So why would it be different for kids with disabilities?
Absolutely. Thank you. CH, your experience in Hong Kong?
Actually, we are serving mainly for the, healthy kids in the kindergarten. So I agree with Nick, but to be honest, I don't have much evidence to say that. One thing I want to point out that SDF is effective, but it is also important to improve the oral hygiene, and also to make sure that the children are away from the cariogenic diet. Caries is still, behavioral disease that because of the poor oral hygiene with, unhealthy diet. So SDF is great, but it's be complement with other factors to make it successful.
Good. Yes, I agree with that. My experience in the clinic is if a child comes with cavities, a young child, then the focus of the conversation is all about the treatment. The parents want the treatment. When you actually use SDF and arrest the decay, you actually have the headroom to start talking about more important things like prevention, about sugar, caries risk assessments, because the focus has gone away from managing a child and restoring a decayed tooth. So I think SDF is very valuable in the first instance in that case.